right, so now I'm going to discuss classification of psychological disorders. I'm going to start with this more broad conceptual introduction to the idea of what defines a psychological disorder before briefly introducing the DSM, our system of classifying and categorizing psychological disorders, and then there'll be a series of lectures devoted to various major categories of psychological disorders. So, in terms of thinking about what constitutes a mental illness or a psychological disorder, the idea is that there has to be a context somewhat for what defines a psychological disorder versus what would constitute normal behavior that maybe other people don't approve of. We used to think of psychological disorders as just being any sort of behavior that demonstrated something that was abnormal or that didn't jibe with society's expectations. Our current and modern conceptualization of psychological disorders is that something is a disorder to the extent that it causes harm and distress. If it's something that impedes your functioning, if it's something that impedes your ability to take care of yourself, impedes your ability to live well and attain meaning, the idea is that a psychological disorder is not merely any aberration from the norm, it's something that causes a significant amount of distress. Additionally, there are certain psychological experiences that are still negative or distressing, but we want to be careful about how we categorize psychological disorders because it's completely normal to experience bad things and to experience negative emotions because of that. Everyone in their life will experience loss at some point and will therefore likely experience grief, which is a sense of sadness at a profound loss. Just because someone experiences grief or experiences loss does not necessarily mean that they, in and of itself, have a psychological disorder. It's normal to feel sad when you experience loss. The idea is the experience of grief rises to the level of psychological disorder when it is distressing and persistent enough as to necessitate professional intervention in order to improve. So we want to be careful about how we categorize psychological disorders. The idea is to make sure that we think about psychological disorders in terms of behaviors that are not just out of the norm, but that are persistent and cannot necessarily just be solved without any sort of professional intervention. The history of treatment of psychological disorders is a somewhat dark and grim history. Certainly, we're not perfect at the way we treat those who are suffering from mental illness in the modern age, but we've come through some pretty dark eras in terms of ways that people who were experiencing psychological distress were treated. You might have heard that in previous eras, individuals thought that psychological illness might be the result of strange or supernatural forces, demonic possession, etc. We now sort of want to take an approach where we understand that some aberrant or abnormal behavior is attributed to psychological illness that we can understand, classify, and treat, and not just to act like it's supernatural properties that we can't necessarily treat in an empirical scientific way. Those that were seen as exhibiting these puzzling, strange, or abnormal behaviors are often kept in atrocious conditions, in inhumane conditions in insane asylums where they were caged and put into straitjackets, where they were strapped down and unable to move, as well as subjected to all manner of sort of horrific physical interventions, such as lobotomies, trepanation, drilling of holes in the skull, forcibly undergoing these medical procedures. And to a certain extent, these were quote unquote cures that maybe gave the appearance of helping these individuals because in some cases it basically fully incapacitated them. If somebody is strapped down or lobotomized, they can't necessarily struggle to try and break free or indicate distress, but clearly this is very inhumane. And despite the fact that there are physical interventions that we can administer onto people who are suffering from psychological distress, there is still a place for psychosurgery today. We have a much more nuanced understanding of how we can properly treat these illnesses to restore a sense of normalcy and well being for individuals who are struggling, or at the bare minimum, try our best to help them function without abusing or torturing them. There were some important shifts in the history of medicine by some influential doctors to shift the previous perspective on psychological illness as the result of um, supernatural forces necessitating some pretty abusive behavior to what we call the medical model. This is primarily associated with famous MD Philippe Pinel, a French MD, who created this entirely shifted model to try and understand how certain environmental factors can precipitate and lead to psychological illness. So, if someone experiences a high amount of stress or just bad conditions in their life, it could be that this is what causes mental illness as opposed to any sort of personal or spiritual failing. So, this greatly shifted this sense of blaming or wanting to remove these individuals from society and emphasize that they should be treated with respect and they should be treated so that they can get the help that they need. And not necessarily with the perspective that we want to cure psychological illness. Obviously, if it can be cured, we would love that. But more so, it appears to be the case that we can improve people's lives by helping them understand how to manage their illness. And this perspective gave a lot more humanity to individuals struggling with psychological illness, and gave them somewhat the sympathy and the tools that they needed to reach a better life. Just a little bit of understanding and a more humane model to how we perceived psychological illness. And so this shift, you could see, has sort of reshaped the way that individuals struggling with psychological illness are treated in various societies and cultures. So, for example, in the United States, the number of people institutionalized in medical hospitals has vastly declined, partially because we likely have better systems for treating psychological illness. Now, it should be mentioned that this might partially be due to a mass closing of mental institutions in the United States because of the horrific conditions that were visited upon these patients. And in one sense, this is merely going to have these individuals who would have been institutionalized and given help sort of hang them out to dry and not give them the sort of systematic, publicly funded help that they might need. But nevertheless, I would say, all things being equal, fewer people who are sent away to mental institutions, the better. And an interesting fun fact about Felipe Pinel was that in some of the asylums that he ran, he in particular wanted to highlight different ways that he could improve the lives and experiences of the patients in these institutions. So, for example, he had the somewhat inartfully named lunatic ball, where the individuals in asylums were given the chance to basically just have a dance and to party and have fun. Again, this is a vast departure from the previous perspective on psychological illness, which is that these are individuals who were not necessarily deserving of fair treatment and dignity. This was meant to be an experience that helped grant a little bit of that humanity back to these individuals. So, with this shift, we see a new terming of the study of psychological illness, which is what we call psychopathology. So, psychopathology is the study of psychological illness or illness of the mind. But basically, this is the modern study of classification of and treatment for psychological and mental illness. A major shift in this field of psychopathology that came about in the middle of the previous century is that we needed to have a good systematic way of diagnosing psychological disorders by understanding the way that symptoms tend to be clustered together. Any psychological illness can be understood to be a constellation of various symptoms, psychological and physical, and an understanding of which symptoms go together can help us give people the proper diagnosis and, as such, get the proper treatment. This is really the end goal of the field of psychopathology. If we can understand how to classify mental illness, we'll have a better and more nuanced understanding of targeted treatment, and in doing so, give people the help that they need. So, you've likely heard of the DSM, so I'm going to talk now a little bit more about what this actually is. This is our standard classification manual for psychological disorders. So, the DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. You'll notice that it says we're here on the 5th edition. There have, in fact, been 5, actually more than 5 because they put out revised versions of a single edition at times, but there have been at this point 5 editions of the DSM. This is because as cultural perspectives shift, we actually see the perspective on what constitutes psychological illness shifting. So for example, when the first edition of the DSM came out more than, I want to say, 70 years ago at this point, homosexuality was considered a psychological illness. Now, we more so, particularly in our culture today, understand that homosexuality, or to be LGBTQ, is not actually a psychological illness. Now, being an LGBTQ individual is associated with higher levels of disorders like depression, anxiety, and substance abuse, but we now understand that this is likely because of the massive amount of stress that being part of that marginalized community puts onto individuals. So, as new editions of the DSM have come out, there have been updated perspectives on how to properly define what is and isn't a psychological disorder and the proper way of clustering together symptoms. So basically, the DSM is a manual that lists all of the currently recognized psychological disorders, and it gives you the diagnostic criteria such that somebody could be diagnosed with that illness. There are specific checklists for what symptoms need to be experienced for how long, and how many symptoms need to be experienced before someone meets the clinical cutoff for being diagnosed with a particular disorder. So the DSM is tremendously influential. It's still widely used. It's not perfect, which is why it is constantly subject to revision, but it still is our best approach for classifying psychological illness. Okay, so the DSM's general definition of psychological disorder is going to be any syndrome marked by, quote, clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. Again, this highlights that point I made earlier, that the behavior exhibited by the person suffering from psychological illness needs to be something that is harmful to them. Being an asshole is not necessarily in the DSM because plenty of people live that way just fine. To be a clinical disorder, the idea is that it needs to rise to a level of dysfunction and maladaptiveness or harmfulness, that it significantly upsets someone's life, their health, their well being, and their ability to take care of themselves. So the psychological disorders are understood to be a certain level of dysfunction that necessitates treatment. And so the psychological disorders classified in the DSM are going to be measured and categorized according to the criteria in the manual. The manual additionally has different categories of illness that exist in different clusters, which I'll get into later. But basically, it has a series of hierarchical organization whereby different disorders belong in various clusters together. Okay. So, psychological disorders, again, these are going to be any sort of patterns of thought, feelings, or behaviors, your classic ABC of affect, feeling, behavior, and cognition, that are in some way deviant, distressful, and dysfunctional. Again, this word deviant has been used quite a bit. This indicates sort of an abnormalcy, but again, I will caution you to make sure that you don't think of psychological disorders as any sort of pattern of behavior that's necessarily just unusual or weird. Certainly, some psychological disorders will have people behaving in ways that are weird, but just being a little bit weird in a way that's kind of kooky, that's not necessarily going to mean someone has a psychological disorder. The deviance needs to rise to a level where someone's life is significantly impeded and their functioning is impeded. And the psychological disorder is going to be constituted of, again, a collection of symptoms that we know tend to go together. Okay? And this idea of distress and dysfunction, again, it's important to note that we conceptualize psychological disorders not just as any way that people can be different from what society might expect, but that this sort of deviance is something that is causing an individual to struggle. So I've mentioned this biopsychosocial approach before. This is basically a approach for understanding human experience, whereby we want to take into account the biological predispositions that someone brings to the table, right? The fact that you have a genetic predisposition, you have a certain physiological structure, you have a certain brain structure, you have certain levels of neurotransmitters. That's going to be influential in whom develops a psychological illness. If you're not carrying any sort of predisposition to a certain psychological disorder, likely it would be the case that it would be very, very difficult for you to get that disorder. Not impossible, because it's not just the biology that you bring to the table, it's the psychological influences that you experience throughout the course of your lifetime. So something like stress and trauma, a lot of the times one needs to not just have the biological predisposition for a disorder, it needs to be kicked off by some sort of stress or trauma. So think about how these two things can sort of go hand in hand. If you have a really strong genetic predisposition to a disorder, you probably need minimal stress or trauma to then experience that psychological illness. If, though, you have a massive amount of traumatic stress in your life, you might not necessarily have had such a strong genetic predisposition, but the stress sort of overwhelmed that biological predisposition. Additionally, you have to think about the sociocultural influences, the idea that we have certain expectations about our lives and who we want to be. There's different definitions that we grow up with of what constitutes normality versus what doesn't. And so the social influences and the environment in your life are going to have a similar sway over your likelihood to develop a psychological disorder. So all of these things interplay to lead to the likelihood or lack of likelihood of developing any certain psychological disorder. In terms of cultural influences, this is an interesting point to make because there are some psychological disorders that appear to transcend cultures. Basically, these disorders present similarly in every culture worldwide. So, for example, schizophrenia and depression are both illnesses that are noted culture to culture and they appear similar culture to culture, right? Someone who has schizophrenia in the United States or in Japan are going to have a similar set of symptoms of delusional, paranoid sort of behavior. Likewise with depression. Interestingly, though, there are some recognized culture bound syndromes. These are psychological disorders that, for whatever reason, only seem to exist in certain cultures. So, partially, this is going to be because your cultural context does somewhat shape what would constitute a psychological disorder. Some behavior that might be seen as highly abnormal or aberrant in one culture might not be seen that way in another culture. And that does matter because, again, our definition of psychological disorder is deviant behavior that causes distress. So that can be a little bit culturally dependent. Examples of specific culture-bound syndromes are all along the list that you see here. Interestingly, anorexia is on the list, and that is because there are some cultures that don't actually have anorexia. It does appear that there's something about a cultural context that can lead to individuals developing anorexia. So there's been some interesting research, for example, that indicated that certain isolated cultures who were not exposed to Western media never had instances of anorexia, but once those cultures did have exposure to Western media, movies, television, magazines, etc., anorexia did appear. So interestingly, there are some cultures that don't have anorexia present. Some other interesting ones on the list, my personal favorite, Koro. Koro, also known as shrinking penis syndrome. So this is a syndrome that appears primarily in some Asian countries. It's particularly associated with Japan. Basically, it is characterized as a delusional belief that your genitals are retracting into your body and will eventually disappear. Now, you might laugh, but obviously this would be the kind of disorder that is extremely distressing to an individual. Thus, it's categorized as a psychological disorder. But this is a disorder that really has never been present in most Western countries, including the United States. So for whatever reason, cultural contexts do lead to certain psychological disorders that will only crop up within that specific cultural context. In terms of overall net numbers of psychological disorders, it does appear that the United States is, again, number one. We do have a higher rate of mental disorders in the United States. We do have a really high population, but other factors in terms of why the United States might have the greatest number of mental disorders, you can honestly pick from a laundry list. Is it because of economic inequality, which we know is a very stressful experience for people? There's plenty of reasons to speculate why the United States might have more mental disorders than any other. As you can see, there's different rates of different disorders. Basically, something like depression is obviously going to be a lot more prevalent than something like schizophrenia. But as you can see, again, the breakdown of disorders within the United States does have different levels within different disorders, and that overall the United States does have the net highest amount of mental disorders of any country. Okay? So, a little bit more on this point of classifying disorders. You might think to yourself that why should we classify disorders? Why can't we just treat people as individuals? Definitely we should, and we should definitely keep in mind that every person presenting with a disorder is not going to be cookie cutter, but there is some usefulness to classifying disorders based on general chunking of symptoms. If we can give someone a diagnosis, we typically have a pretty good understanding of the prognosis and how that disorder is going to progress. For example, if somebody is diagnosed with a major depressive episode, we know that their likelihood of reoccurrence is quite high. As such, we can be proactive about keeping people on sustained treatment or making sure that they have the resources that they need should their depression reoccur. So, an understanding of how disorders are likely to unfold helps give people more of an understanding of how they should approach treatment. Again, there's different treatments that tend to work for different disorders. Once we classify a disorder, we tend to have various ideas of what a good follow up treatment would be. For example, if you develop depression or anxiety, the first course of treatment is likely going to be CBT. That's the most common treatment approach, and it tends to work for those disorders. There's going to be very different courses of treatment for someone who presents with schizophrenia or a phobia. For example, a phobia is going to be more so treated with aversion or exposure therapy. Additionally, if we have an understanding of the categorization of disorders such that we have a better understanding of how they work and how many people tend to have various disorders, it can help prompt research into the disorders that need the most help. Okay, so now let's look at a couple examples of how categorization in the DSM works. Basically, any particular disorder that you look up in the DSM will have a checklist associated with it. It's going to have a series of symptoms that an individual with this illness might suffer. Different disorders have different criteria for how many symptoms one must experience for how long and how many of the criteria must be met. So, for example, to be categorized with insomnia, people need to meet all of the criteria on the symptoms list. They would need to have experienced all of those symptoms. Typically, there is a specified length of time that someone has experienced the symptoms or how often they've experienced the symptom. And they need to hit all of those check marks before they get the official diagnosis of insomnia. The idea, likely, is that having some trouble sleeping sort of off and on is completely normal, and it might be due to other causes. To get that official diagnosis of insomnia, we need to see a more sustained pattern of more distressing symptoms. ADHD, for example, this categorization is pretty complicated, but this is the way that classification looks for a fair amount of disorders. So the instructions for the checklist for ADHD states 6 or more symptoms of inattention for children up to age 16, or 5 or more for adolescents 17 and older, and adults. Symptoms of inattention have been present for at least 6 months, and they are inappropriate for developmental level. So notice all the ways that the language there is quite specific. It specifies a different number of symptoms that would be present for younger individual as opposed to older individuals. The idea is that for a young child, more hyperactivity is likely developmentally quite normal. So you need to present more symptoms if you're a young child. Now, as you age into adolescence and adulthood, you develop a greater ability to control yourself. So, in order to meet that criteria for ADHD, you technically need fewer symptoms to meet that threshold for ADHD. So, it takes into account the age of the individual. It takes into account how long the symptoms should be present. It says 6 months. And additionally, it specifies that it should be out of step with appropriate development. So then you get into the actual list of symptoms, and these would be the sorts of things you typically associate with an individual with ADHD: hyperactivity, trouble concentrating, difficulty following through, difficulty with organization, easily distracted, forgetful, etc. All of these are the individual symptoms that might make up ADHD. So an individual needs 6 or more if they're younger, 5 or more if they're older. Okay, so you might think that this system is a little bit complicated, but it's specifically created to, again, take into account what actually is ADHD versus what is normal development, and it takes care to try and be as specific as possible. One more thing to note before I move on is that you might notice that logically, if someone only needs 5 of these symptoms, and there's a longer list than that, there appears to be about 9 symptoms, one individual with ADHD might be behaving in a completely different way than another individual. So this is a system that lets the different ways that ADHD manifest look different and still fall under the ADHD umbrella. And again, despite the fact that you might think that classification is going to lump people all together and treat them as all the same, this specific structure for the list makes it so that different individuals who are experiencing ADHD in different ways can still get their diagnosis. There's an entire separate checklist on ADHD regarding hyperactivity and impulsivity that simultaneously needs to have a certain amount of symptoms present for a certain amount of time. Oh, and in addition, there's several more symptoms that are possibly associated with ADHD. Then, based on the combination of symptoms, ADHD can be broken down further in terms of the specific way that it's manifesting. So, combined presentation, predominantly inattentive or predominantly hyperactive. This again takes into account that not all individuals with ADHD are the same, and lots of different kinds of manifestations of behavior can still fall under the ADHD umbrella, despite the fact that some individuals are going to be more inattentive versus some are going to be more hyperactive. We still get a solid idea of how we can treat an individual with ADHD once they get this diagnosis. So again, the way of classification according to the DSM varies from relatively straightforward to as complicated as this ADHD classification, but all of this is done with an eye towards how these disorders can manifest and how we can best treat people. Now, obviously, the DSM isn't perfect. Now, a few of the criticism, one is that there are so many symptoms and so many disorders that exist within the DSM that it might be the case that technically, according to the DSM, there's far too many people who could be considered to have something out of the entirety of the DSM. So it might lump too many people into this quote unquote disordered classification as experiencing some sort of a mental disorder. Now, obviously, overdiagnosis is a problem, and we want to make sure that we're not giving people reckless diagnoses that aren't accurate to what they're experiencing, and certainly we want to be thoughtful about when we give someone treatment. So this is definitely a problem with the DSM. I would say that this problem can be addressed by making sure that we're careful with how we use the diagnostic criteria. Sometimes classification can seem a little bit arbitrary. For example, if, let's say, you're an individual who's being potentially diagnosed with ADHD, but you only present 4 symptoms as opposed to 5, you technically don't get your diagnosis and you wouldn't necessarily get the treatment that an individual with ADHD might have. You might call these cases subclinical because they're very, very close to the official criteria, but this could be considered a somewhat arbitrary cutoff, which is a problem. How do we get people treatment if they're just under the classification level according to the DSM? Now, additionally, as I mentioned, the cultural context is inevitable, and the idea of slapping a diagnostic label on something reflects the sorts of behaviors that we deem normal versus what we don't. Additionally, to receive a diagnosis can have some negative influences. It's important to have a diagnosis so that you can get proper treatment, but at the same time, if you get a diagnostic label, it might make you feel like that's something that's true about you that you really can't help. And it might, in a way, lead to a self fulfilling prophecy whereby people treat you as though you are your diagnosis, and you might treat yourself as if you are that diagnosis. And again, to take the example of ADHD, hyperactivity in children, it's normal. They're kids. They get excited. They like to play and run around. They have a lot of energy. We need to be careful to make sure that we're not pathologizing normal behaviors, even if there's something that we find annoying, right? A child who's acting hyperactive, you need to be really careful to think about whether or not that's a behavior that actually necessitates clinical intervention or if they're just being a normal kid. Because once you slap that label on someone, it can change the course of their life going forward. Now, one interesting point to make towards the end of this lecture, this point about the insanity defense. So I've avoided the use of the word insane because I really don't think it adequately captures the experience of psychological illness. Right? If you're someone who suffers from depression, would you necessarily jump to calling yourself an insane person? It just feels a little bit too severe. So, this insanity defense, the idea that to have a mental illness can in some ways be a legal defense in the court of law, should you be on trial for committing a crime, has a very controversial history. So, you might think that it's easy if you are ever in legal trouble to just plead insanity and it gets you off the hook. It's really not going to be a perfect solution to getting out of trouble. A relatively small amount of individuals end up using this option because it is a sort of a last resort. To take an insanity plea, you do need to demonstrate that your mental illness made it so that you couldn't, for example, appreciate the crime that you were doing, or maybe you had no idea what you were doing, maybe you completely don't remember what you were doing. Um, so it takes quite a lot to try and prove that this was the case. And additionally, should you end up having an insanity defense, it might be the case that you end up in as restrictive and unpleasant an institution as prison. So just because you're found to be legally insane doesn't necessarily get you off the hook. The criminal justice system is still going to want to make sure you're not on the streets able to commit new crimes. So, despite the fact that it might seem like the quote unquote insanity defense is a way that people can get off the hook by blaming mental illness for their terrible behavior, it's really not necessarily quite like that. It's not very common, and it doesn't necessarily, like I said, get someone off the hook. Additionally, it's important to keep in mind that the vast majority of psychological disorders are not characterized by violent behavior. People who are mentally ill are actually far more likely to be the victim of a violent crime than the perpetrator, likely because of the way that society mistreats people with mental illness and doesn't necessarily get them the help that they need. So definitely keep in mind that despite the fact that there are some psychological disorders that can be associated with violence, like antisocial personality disorder, or people who are undergoing a psychotic break, they might become violent. The vast majority of people who are experiencing psychological illness are the ones suffering, and they're not likely to become violent. But given that it is possible for certain psychological disorders to manifest in violence, it is important that we understand what these disorders are and have a thoughtful approach for how we treat them. And then lastly, this is just a long list of factors associated with risk for mental illness and protection. So, obviously, like I mentioned, we have a much more nuanced understanding of the context in which psychological disorders present. This biopsychosocial model gives us lots of ideas about where psychological illness can come from and how we can be protected against it. So, some interesting ones I'll call your attention to. For example, low socioeconomic status is a factor that's greatly associated with risk for mental illness. Whether it's the stress that is associated with socioeconomic status, we can't necessarily be sure. Whether it's lack of access to other sorts of healthcare that lead itself to risk factors. Overall, we do know that socioeconomic status is associated with psychological illness, and as such, part of how we seek to improve outcomes for those with psychological illness, one approach would be to try and help improve economic inequality. In terms of protective factors, again, I'll just point you to a couple. For example, exercise. Exercise can be something that's protective. Again, if an individual is suffering from, let's say, depression or anxiety, maybe the thought of exercising is the last thing that you can stomach, but we do know that exercising can help boost your mood, it can help boost your endorphins, and it can make you feel better. So if you're experiencing a lot of stress, trying to make sure to at least get outside and take a walk can be a wonderful protective factor. Additionally, this feeling of control. Now, feeling a lack of control, this characterizes certain disorders, for example, depression. This is also the kind of thing that we can help people develop, likely in a bout of talk therapy, helping people understand the things in their life that they do have control over and highlighting the things that you can do and the things that you are good at. This can be a pretty effective treatment for helping pull people out of low points, and it definitely can help be a protective factor. So, this biopsychosocial model gives us lots of ideas for where mental illness comes from, and on the other side, gives us lots of ideas of how we can help protect people. Okay, so I'm going to end it there with the brief introduction to psychological disorders, and I'll be back with the actual classifications of various disorders from the DSM.